CSICON 2019 being held at the Ashoka Hotel, New Delhi. I am Dr. Rahul Kotwal, representing Medical Affairs team of Macleods Pharmaceuticals. Today we have Dr. Arindam Pandey with us, who is an interventional cardiologist at Medica Superspecialty Hospital, Kolkata. He has delivered a session today on CRT for all patients of DCM and LVBB. So sir, we welcome you at our channel and request you to summarize your session for the benefit of the fraternity.
Thanks, Dr. Kotwal. So basically we all know CRT is a very innovative and novel therapy which is applied for patients who are suffering from dilated cardiomyopathy, so whose ejection fraction is actually reduced. So what this device does, it improves the ejection fraction as well as symptom of the patient, and it also improves the long-term mortality. In this subgroup of patients, very important the mortality, because they are very high risk patient for mortality. Their 1-year mortality is around 20%, as we all know, and their 5-year mortality is as high as 50%, which is higher than many of the cancers. So we need to improve the mortality, at the same time we need to improve the symptom of the patient. We need to reduce the recurrent hospitalization, which are real problem in this subgroup of patients. Now the topic which I was allotted was, should we apply this novel therapy CRT? CRT is actually a triple chamber pacemaker, as we all know. Normally there are 2 leads in dual chamber pacemaker. In CRT there is another lead which is there in the LV, which is implanted through coronary sinus in one of its tributary. Now this triple chamber pacemaker, what it does, it improves the synchronization of the left ventricle. As we know, in dilated cardiomyopathy patient, there are 3 types of dysynchrony: atrioventricular dysynchrony, interventricular dysynchrony, and intraventricular dysynchrony. So CRT actually improves all these 3 dysynchrony. Now the topic which I was allotted, should we apply this novel therapy to all patients of dilated cardiomyopathy with left bundle branch block? Now while I was delivering, I was just mentioning there are actually very important differences in different guidelines in this respect. So what is not mentioned in the topic is very vital part, the duration of QRS in ECG of this patient, which is very important and very relevant. There are very good number of studies, randomized control trial, which has clearly shown if the QRS duration in the ECG is more than equal to 150 millisecond, the patients are going to respond with this novel therapy. Otherwise, if the QRS duration comes down gradually, the chance of response actually also is reducing. So in different guideline also, there are some controversial aspects. Say for example, in the individual with LVBB with QRS duration of 130 to 149, some of the guidelines says, say for example, in ESC guideline, heart failure says it is actually a class 1 indication with level of evidence B. Whereas other guidelines, say for example, American College of Cardiology AHA guideline says no, it is not a class 1 indication, it's a class 2A indication. So there is some doubt regarding this because of lack of evidence, and more controversies are there if the QRS duration is further low, say for example 120 to 130. In this subgroup of patient, the ESC heart failure guideline says it is class 3 indication, that means it doesn't help, we should not do it. And older guideline of ESC itself, ESC Heart Rhythm Society guideline, they say no, it can be done. It can be done, but the level of evidence is not very strong. They put it a class 1B recommendation in this subgroup of patient. Whereas other guideline, say for example, American College of Cardiology guideline, they say it's a class 2 indication. Whereas newer guideline, Canadian guideline, it was published in 2017. They say it is a class 3 indication. So why is it so? Why there is so much of difference? This is because of new studies which evaluated this subgroup of patient. One study known as ECO-CRT study, which evaluated applicability of CRT in this narrow QRS complex, QRS less than 130, which not only failed to show the improvement, it also showed that there might be higher chance of mortality. So it will affect adversely. So it is very important to consider the QRS duration of the patients before implanting the CRT, because CRT is an expensive device. and we are from a resource poor country. So we should be very, very meticulous in choosing our patient.
Right.
I personally feel we should apply this therapy to patients who has a very clear-cut indication. Say for example, class 1 indication, if the patient is having ejection fraction less than 35% with left bundle branch block morphology, QRS more than equal to 150, there is no doubt in this subgroup of patient, we can definitely go for it. If the QRS is less than that, we should apply our knowledge and we should individualize the patients. And not only the LVVV morphology of, is important, the pattern of LVVV is also important. There is something called strict LVVV, where there is notch. There is a notch in the LVVV arm, which should be present at least in 2 continuous lead. So if that is present, there are study which is published in the first half of this year only in PACE, which clearly shows that this subgroup of patient actually wonders. They are very good responder of the therapy. Right. So all those factors are important, not only LVVV, the pattern of LVVV, the QRS duration of the patient, and ejection fraction, symptomatic class. If everything matches, then only the chance of response is improved, and we should actually choose those patients only in a resource poor country like India.
Right. So sir, it was a wonderful description of your session. So what take-home messages would you like to give to the viewers?
So take-home message will be, there has been tremendous improvement in the pharmacotherapy of the heart failure patient. We do have newer molecule in the form of RNA and all. At the same time, there are newer algorithm which is coming in this novel CRT devices. There are now, quadrupolar lead, multi-point pacing, newer algorithms, say for example sync AV or LV only pacing. They have improved the response rate of the CRT to large extent, but still we should not forget the basics. Most important part in the CRT response is the proper choosing of the patient. So indication wise, we should choose very, very proper patients. They should all be having ejection fraction less than 35%. They should all have a LVVV morphology. More so if there is notched LVVV or true LVVV or strict LVVV, and if the QRS is more than 150, then the response rate is very high, and actually wider the QRS, higher is the chance of response. Right. So if we choose this kind of patient, this subgroup of patient, then they will benefit from this therapy very well. So that is equally important.
Wonderful, sir. Thank you very much for being a part of our channel today. Thank you.